Hello, my name is Ellie, and today I'm going to be talking about LisFranc injuries. To begin, I want to kind of go over some of the anatomy that is associated with LisFranc injuries, and specifically kind of talking about the overall foot and ankle anatomy, because when we are discussing LisFranc injuries and the mechanisms that are associated with that, we want to rule out some ankle pathologies that may have occurred during that time of injury. So, for the bony anatomy, we want to look at again the foot, not only just the foot, but the ankle as well. So, looking at the metatarsals, the cuboid, the cuneiforms, the navicular, the calcaneus, the talus, the tibia, and the fibula. And then going off of that, we want to look at the muscle anatomy. Again, not just looking at the foot, but looking at the ankle as well to make sure that there were no associated injuries with the LisFranc mechanism. So some of the key muscle anatomy that we want to look at is the tibialis posterior, the tibialis anterior, the extensors of the foot, the flexors of the foot, so the dorsal and plantar aspect of the foot. We want to look at the Achilles tendon, and we also want to look at the peroneals. And then same concept, we want to look at the ligamentous structures that are associated. And as you can tell in this picture, there's quite a bit, but some of the key ones that we want to look at are on the medial side, so that deltoid ligament of the ankle and those associated ligaments with that. And then we want to look at the lateral aspect of the ankle and evaluate those. We also want to look at the LisFranc ligament as a whole, and then the cuneo-navicular ligament and the cuboid-navicular ligament. So when talking about LisFranc injuries, we can kind of break them up into three sections. So we have fracture, we have dislocation, and then we have a combination of both the fracture and the dislocation. The fracture dislocation is the most common that we're going to see, and those are associated with that high energy, as I'll talk about here in a minute. So when looking at like the mechanism of these types of injuries, the foot is typically placed in that hyperplantar flexed position, and there's that axial load that is being applied down. So like I said earlier, we can kind of break that in to two types of mechanisms. So we have high energy, and those are associated with more of that trauma based. So we see those a lot in motor vehicle accidents, motorcycle accidents, falling from heights, and those types of accidents. And then we have low energy, which we see associated more with those sports related injuries. And we see those most commonly in that high impact sport. So we see it a lot in football, rugby, but we can also see it in soccer, gymnastics, running. And then diving deeper into that, we can break them up into categories. So we have kind of a general overview of three categories: type A, type B, type C. And then type B and type C can be broken up into two other categories. So I have this image here that kind of illustrates the types I'm talking about. So type A is like that total incongruity of all of the metatarsals. And then type B is that partial, and then of partial incongruity of one or more metatarsals. And then type C is what they call that partial displacement, the divergent displacement. So getting into the evaluation, we always want to start with taking a good solid history, especially for those injuries that aren't necessarily those acute or traumatic LisFranc injuries. We want to kind of dive into what could be causing this. So some key questions that we want to look into are, of course, like what were they doing when this happened? We want to make sure like we look into the shoes they were wearing, the surface that they were on when this happened, to kind of take a deeper look into things. We also want to ask, of course, a previous history, if not only of this type of injury, but any other type of injury. We want to have the patient rate their pain on a scale of 0 to 10, kind of keep track of that along the process. We want to ask, does the pain ever go away? Does it only occur when they're doing specific activities? Is it constant? Does it go away with rest? Making sure that we're asking those kind of questions. And then to kind of take a deeper look into things, we can ask, did the patient hear pop? Did they feel a snapping? Because that can kind of rule in and rule out some things. The next part of the evaluation is observation. So we want to look at the patient's foot. We want to, specifically with a LisFranc associated injury, we want to check if there's any bruising, ecchymosis over the plantar aspect of the foot. We want to check for swelling. A lot of the times these types of injuries will have swelling around the midfoot, which can extend proximally to the site of the injury. And then taking into account that for those low energy mechanisms, swelling may not always occur right away. So reevaluating a few days after, asking the patient, do you notice that you are more swollen? Just making sure that we're taking account for those low energy. We also want to look into foot posture. Having pes cavus foot posture can put you at a little bit more of a risk for LisFranc injuries. Also, with that is toe length. So when we're doing range of motion, we want to, again, like I said before, we want to take into account ankle and foot. So having them do dorsiflexion, plantar flexion, inversion, eversion, and then that toe extension, toe flexion. And we can do that for active range of motion and passive as well. And then for manual muscle testing, again, making sure we're testing the strength of not only ankle, but foot to kind of rule out associated pathologies. So assessing dorsiflexion, plantar flexion, inversion, eversion, toe extension, and toe flexion. This is kind of just an extension of the anatomy that I talked about earlier, but palpating those key landmarks, again, we want to palpate those cuneiforms. We want to go to the base of all the 5 metatarsals, the cuboid, the navicular, palpating all the muscular structures, ligamentous. And for a patient who may be experiencing a LisFranc injury, they may have more like tenderness to palpation along those metatarsal heads, also along those 3 cuneiforms, along the cuboid, and just generally over the plantar aspect of the foot. And then with palpation, we can assess the pulses. So we can assess the tibialis posterior and the dorsalis pedis pulse, especially for those high energy mechanisms. We want to make sure that there was no neurovascular damage. So like I just mentioned, when we're doing that palpation evaluation, we want to assess for that neurovascular want to make sure that there was no neurovascular damage. So assessing those pulses, checking the quality and the quantity of it. So making sure if it's strong, weak, if it's fast, if it's slow, and noting that in your evaluation. We can also assess the dermatomes and myotomes associated with that area. And then we can also look into reflexes, making sure that we are checking for hyper or hyporeactivity. So LisFranc injuries can be quite difficult to diagnose, and ultimately at the end of the day, imaging is going to be the most timely and appropriate test to further assess for these injuries. But we can do some long bone compression, making sure obviously there's no obvious deformity. So maybe for those more low energy mechanisms, we can be doing that long bone compression. We can be using the tuning fork. We can do those intermetatarsal glides, assessing for the integrity of those ligaments. Another big thing that we want to look into is the Ottawa ankle rules, making sure that the patient is not having any of that bony tenderness, is able to weight bear, and ultimately using that as a guideline to decide for further imaging. And then when we assess outcomes, we can look into a few things here. LisFranc injuries can cause some lifelong complications and can be associated with overall decreased function and mental health. So using these patient-reported outcomes throughout a patient's recovery is really important because we can pull out the things that we need to be working on and focusing on. And those are my references. Thank you.